Hi, my name is Megan and I'm here to tell you a little bit about intubations. You would like to do an intubation if the airway of a patient is compromised, if your patient is in respiratory failure, and if you need to protect your patient's airway for any reason. Although tube size does vary from patient to patient, the standard sizes for a male is an 8.0 to an 8.5, and for a female you would like to use a 7.0 or 7.5. Although, like I said, it does vary from patient to patient. Some indications for an intubation are as follows: the inability to protect airway adequately, the partial or complete obstruction of the airway, apnea, respiratory distress or hypoxemia, hypercarbia or acidemia seen on the ABG, oximetry, or the exhaled gas analysis. The advantages are as follows. The insertion is faster and easier and less traumatic for your patient, and it's also more comfortable. There's easier suctioning. It's going to decrease your work of breathing, and there's a reduced risk of your tube kinking. Some of the main disadvantages of intubation are there's a greater risk of your patient self-extubating themselves. Aesthetically, it's displeasing, especially long term. It may require an additional use of your oral airway, and there's a great risk of retching, vomiting, or aspirations. You should have no more than 30 seconds per intubation attempt. If it fails, immediately ventilate and oxygenate your patient for 3 to 5 minutes before trying again. The number 3 curved Macintosh or straight Miller blade are commonly used to intubate adults. For your cuff pressure, you need to check that every 8 hours, or if you were to hear a leak in the endotracheal tube. You usually want your cuff pressures around 20 to 30 centimeters of H2O and between 15 to 22 millimeters of mercury. Today we're going to show you how to intubate. You'd like to have your suction hooked up and ready. You need your commercial tube holder. We have 2 different size tubes here. We have an 8 and a 7. This one we usually use for a female, this one we use for male. You need your syringe to fill your inflation. You have your CO2 detector. You have your bag and mask. Sometimes we need the lube. And then here's our blade that we're going to use as well. So first you want to make sure your bed is flat. You usually can take out the back of the bed, the headboard. You're going to remove any pillow. You want your patient in the sniffing position. We're going to give a few breaths to get the patient ready. You need your stylet. Stylet into your tube. Right. And then are you ready? All right. Okay. Yep. You're going to insert into mouth. You're going to pull down on the tongue, and you're going to be able to see the vocal cords. You're going to put your tube down into right between the vocal cords there. Pull out your stylet. You're going to inflate the cuff. We have your CO2 detector hooked on, and you want to look for adequate chest rise and fall. And you always want to listen over the stomach to make sure no air is getting down there. All right. We're going to put the tube holder on. Secure this under the patient's neck.
And until you get the tube holder on, you want to hold on to the tube at all times. And after you get it all hooked up and hooked up to the ventilator, you want to get a chest x-ray to make sure there's proper placement of the ET tube.
All right, that's good. To confirm your intubation, you would like to check for bilateral breath sounds. You're going to look for symmetric chest movements. You're going to have your CO2 detector. It's going to be hooked up to your resuscitation bag, and you're going to make sure that you have exhaled gas. It'll turn purple if so. And the doctor or physician will order a stat chest x-ray to confirm proper placement, and you want it 3 centimeters above the carotid.